So my name's Stefani Hartsfield, for those of you who don't know, and I'm the SASH Operations Manager for the statewide administration. So I just wanted to talk a little bit. So my section today, Bob's going to talk a lot about what are the HIPAA laws and rules and what does it mean for us. I also want to talk about, what is the participant folder, both electronic and paper, and what does that mean? And we used to, before we had DocSite, we used to talk about why do we have an entire training just on a folder of where we keep our records, because it was somewhat boring. And we didn't used to have a training on it. We would just say to people, read chapter 12. It explains what needs to be in the folder. It's pretty clear. And then if you have questions, let us know. But I think you all have probably already learned that this is a pretty busy job, whether you're a SASH wellness nurse or a SASH coordinator. There's a lot going on. It's a lot to learn, and you have a lot of people coming to talk to you, which is the greatest thing about the job. There's a lot going on, and it's hard to make time to pause and say, am I doing this correctly? Am I documenting correctly? Am I storing it correctly? And am I just taking the time to make sure I have what I need? So we switched it around, and we're pretty much forcing you to take the time to look at something fairly dry but really important, especially around the type of information we're storing, to make sure it's done correctly. So that's why we do this training. And we do talk about paper folders just to make sure that it's done correctly, because it is pretty important considering the fact that we do have people's health information, and it just has to be done correctly and done well. So that's why we do it. It's easy to get lost in the shuffle of our busy jobs. I have this very intense graphic of a locked file cabinet up here. And that's just, you'll hear several times that everything needs to be locked. We'll talk about DocSite. DocSite is a secure website. Hopefully most of you can access it from any computer, any iPad, any laptop, but it is a secure password protected website. I make sure that you only have permission to access the sites that you should be working at and the participants who signed their use and disclosure for your site. So that's all got a lot of protections in place electronically, so it's fairly secure. There's further steps Bob will talk about to take as well. But with your folders, it's easy to make a very very simple, I guess not a mistake, but just leave things out without realizing it. The best of intentions, but you get up to go to the bathroom, you walk away from your desk, someone distracts you, and you can leave, just someone's manila folder on your desk without realizing it. And no ill intention was meant, but it does happen. And it's those little things that we just need to take a second to pause and reflect on and make sure that we're really paying attention to. So the picture of the locked file cabinet is there to really kind of frame in your mind that I know some of you are still getting offices set up, you're still trying to get equipment in your offices, but really stress to your supervisors, if you don't have a file cabinet yet, they need to get you one, even if it's a little one from Staples, and it needs to have a lock, because you will have a paper folder on each person with a minimum of documents in it, and it needs to have a lock and key. And when you leave your office, if your office door isn't locked, then that file cabinet needs to be locked, or at best, both of them are locked because it has secure information in it. And I want to say, too, if you're a person who moves from building to building, who is either does community work or has several sites, which most of you are at this point. We have less and less people who just stay in one building with one office all the time. You can get a locked file cabinet that you can carry with you. It wouldn't be all the files all the time, but if you know you're going to go out and do assessments on the following 6 people and you want it, most of it's in DocSite, hopefully you'll be carrying less and less paper with you. And we're really at a point now where you shouldn't have to carry too much paper, but you might want to carry some paper assessments that you've done or just some printed out case notes. Get yourself a little locked cabinet or a rolly bag that you can put something on, but it does need to be locked, and if it's in your car, it needs to be locked in your car. So really kind of pay attention to those little things. And we did do a training on May 6th for what are called the privacy officers at every housing organization, who are most of your supervisors. It's usually an officer of the organization, and we went over this with all of them. So whomever you work for should not be shocked to hear you come and say, hey, I really don't feel comfortable because I'm going from site to site. I'd like a locked box to keep in my car, or I don't have a locked file cabinet in my office. Can I order something? They should be prepared for that. And they want to support you in that, because no one wants a HIPAA violation. So, one thing that we realized when we were preparing to talk to all the housing organization privacy officers is that they get a little bit nervous because they're like, oh my God, we're going into healthcare, we're collecting all this information that we've never had before. But as we were researching it, yes, it's different because with SASH, we are collecting more health-related information than we've collected before. It's also not that different. So if you work for a housing organization, if you have worked for a housing organization before and now you're moving into a SASH role, or maybe this is all brand new to you, working for SASH, it's not that different because most of us with our HUD financing and affordable housing, we've had to collect a lot of confidential information in the past, and a lot of it's health related because in order to get vouchers and rent discounts, basically, is you have to sometimes collect people's pharmacy bills, you have to collect their medication information, and you're asking a lot of this similar information, not quite as detailed, but it's actually still health information. But before, because we hadn't dived so deep into this health realm, we weren't quite as knowledgeable about HIPAA rules and everything. So really, it's not that different, but what's great is we now have some really deliberate protocols in place for working with HIPAA and knowing it. And so we've always had confidential information, and housing organizations have always been really good about keeping financial information confidential and those medical receipts that come in that affect people's rent. So it's similar, yet different because we need to be that much more careful. And really the key is in knowing how to protect the information and handling it with care. So we want to help you through that. I think you all know it. A lot of it's common sense, but we really are just giving you the tools and taking the time to make sure that it makes sense to all of you. So we're going to keep talking about what are the trainings and protocols in place so that you know what to do. So about those protocols and trainings, so I'm not going to go over it with you. Whoops, I think I wrote the wrong chapter. See if anyone can catch my typos. What? Okay, so what chapters should you review?
11 and 12.
Yes, very good. We're going to have some trivia. Good. I put that in there on purpose to make sure no one fell asleep during the HIPAA training. Very good. Yeah, so review chapters 11 and 12 in the SASH Operating Manual. So chapter 11 is about confidentiality and HIPAA. It's not long. It's the short do's and don'ts going over some basics. But if you just want to review it, and if you're curious in a SASH specific way, you want to look at that. So look at both of those. I'm not going to go over them in a lot of detail here today because they're very clearly laid out. And for those of you who aren't familiar, haven't gone, I just want to show you how easy it is, which I think you guys have seen this. But you go to sashvt.org, and then over here on the right, can you all see my screen?
Yep.
Yes? Okay, good. Then you go into the SASH forum. And then in the SASH forum, the operating manual is a place you're going to want to go for just, everything on how to do SASH is there. And then the password is SASH user, top secret. So, and then here in this then you just click into the operating manual, and it brings up this PDF. And this is where all those chapters are for you. And so then I can just click, if I want to look at chapter 11, I click here and it takes me to chapter 11. And so this is privacy and confidentiality in SASH. It has examples, has some of the things happening there. And we're going to go over a lot of that today. So the other thing that I just want to talk to you, so in chapter 12 is talking about what needs to be in the hard copy record and the electronic copy. The electronic record is DocSite. So you're going to have several times where we talk about DocSite, whether it's the DocSite training, and today we'll talk about what's in DocSite. As far as the hard copy record, some of you who are joining on to existing sites or have expanding sites, you may see a blue folder that looks like this, and here reference to blue folders, and these were fairly complex participant folders. They have multi-tabs in here, and everything had to be in a specific order. You don't have to have these anymore, so throw those out. I don't really throw them out. If you join onto a site that had those blue folders, it's fine. You can keep those and keep using them. If you're starting a new site and you're wondering about those, you don't need to get anything that complex. They're expensive. At this point now, when you start a participant folder, a good old manila file is fine. what the difference is before we had DocSite, we had to use these very rigid blue folders with multi-dividers to keep everything in there because everything was on paper. So your medication list was in there, your case notes, assessment info. It was all in there. It was all divided out, and there was a lot of information, so it needed to be kept clear. Now that we're on DocSite and everything's electronic, we don't need to have something so specific. What you do need to have in hard copy in that paper folder, and this is what's listed in Chapter 12, is you need to have the legal forms that they sign. And I think you all know those 4 key forms, the authorization for use and disclosure, the waiver. So, and that's what's listed here in Chapter 12. Whoopsies. Make sure that you have a hard copy of those forms. They can also have a copy of those forms, as you know, but have each of those in there. The other things you're going to want to have that are not in DocSite right now, although Healthy Living Plan is transitioning, is I would have a copy of their Healthy Living Plan, their most recent, and a copy of that person-centered interview summary, because that's not in DocSite either. The other thing is, and after that, it's up to you. If they go in and out of the hospital, there's an after-visit summary. I would put a copy of that in there. Anything at your discretion. Something comes in from the family, then it's at your discretion. Go ahead and keep whatever hard copies of things you have in there. We're working with DocSite to try and be able to attach like PDF or scanned documents so that everything's really in DocSite, including Word documents, but it's not there yet. Yeah. The question is, should we keep on to hold of paperwork from 2 and 3 years ago, old assessments? I would say, yeah, do keep them. Basically, and if people are asking too, if someone is deceased or has moved out, we need to hold on to it for 7 years, that paper record. So that's the rule. You don't have to keep it in your main file drawer right up in your office. So some of you have storage places where I imagine your housing organizations move files for deceased or people who've moved out. You can move it somewhere else, but we can't shred it until after 7 years. So I would hold on to that. Another thing that you're going to want to keep is a copy of the clock drawings, and we'll talk about this on June 24th at the assessment training. Don't get rid of those clocks because you really need to look at clocks year after year and how they change over time. So they're keeping old assessments are good. Yeah. I mean, historically, the data on an assessment, once it's been entered into DocSite, it's all there. All the historical data is there, but I wouldn't get rid of things. If there's things that seem really silly, maybe, but I'd err on the side of caution. So the paper folder really should be minimal because most of it's in DocSite, but I also wouldn't get rid of stuff just because we do have to be fairly careful. So look at Chapter 12. The one other thing is that Notice of Privacy Practices. I want to go back and just make sure everyone knows that it has been updated, and it's right. It needs to be on the website of all of your organizations, which we told people at the privacy officer training. It's right here on the SASH website if you want to see what it looks like. It's right there, and you would modify it. This is a general one, but there's also one that can be modified to your organization, which is on the forum where all the forms are. Yep. So forms can be tailored, but keep that Notice of Privacy Practices and the date that it was given to the person so that they were made aware of it, in case anyone says, no one ever told me about this. So it's those legal forms you really need a copy of. That's really what goes into the paper folder. And then the electronic folder, which is the other side of Chapter 12, it's DocSite. And that's, you guys, we've been over kind of what to put in there if you've been to a DocSite training. If you haven't, we'll get you trained. And that's the rest of that record and what to keep in there. So I just briefly wanted to go over case notes, and because case notes are part of the record, and they're a big part of it. And I think that depending on your background, if you're a nurse, you do get trained on how to document case notes, but we are finding that nurses are all trained differently on this. There's no one way to do case notes. There's best practices. There's some things you definitely shouldn't do. Some nurses do SOAP notes, which I can't even remember what it stands for. And I don't think they teach it anymore. Some do different notes. And then for SASH coordinators, you may be a social worker, you may have a psychology background, you may have come out of housing. Everyone has really different backgrounds. So what we want to try and do is just come up with some basic guidelines around case notes, because it can be really hard. If you're a SASH coordinator and you do work in a building and you see someone every day when they check the mail, do you need to make a note every time you see them? No, because that would kill you. You'd never get anything done if you're like, saw Mary today, she got her mail. That just wouldn't work. But then as a SASH coordinator, it's tough is when do you make a note? And so we want to try and help you with some guidelines around that. So I want to briefly touch on a couple because it does relate to record keeping and documentation. So, I've been looking at nursing articles and working with some of our lead nurses around this, but I liked a couple of these quotes just to get you started on this. And this one says, good record keeping enhances patient care, giving a clear and purposeful record of both care given and care planned so that all health professionals can achieve the best outcomes for their patients. And I like this just because we do work on a multidisciplinary interprofessional team, and you can print out case notes both for the participant and for your partners on your team. So I think when you're writing your case notes, keep that in mind. Would the participant read this? Would they agree? Does this seem reflective? And is this going to be helpful for the rest of the team in knowing what direction we're going to go? So just some things to keep in mind as you're writing those case notes. And keep them brief if you can, but if you can't, if you really need to put a lot of detail, that's okay. Okay, so I have some questions, more trivia. Okay, so where are case notes recorded in DocSite? Encounter notes, okay, good. All right, so that's one of them. I'm not going to hit enter because I have something else. Okay, so from one of the other sites, what's the other place where you can put in case notes? It's called Visit, Comment, Review, which is a little crazy. So we can have, but if you just want to go put in a case note, you can do it off the online visit planner called Encounter Notes. Good job. Or you can click Visit, Comment, Review off that left-hand side, and that's just for a case note. So, okay, good. So it's confusing because why would it be review if you're entering? I don't know, but that's what it is. Okay, next question. Why record case notes? So record the reason a decision was made. Really put the reason. So not just, called PCP regarding this, but why? Why did we decide? Or not made, and the actual intervention taken or not taken. So decided not to pursue, hypertension medication for this reason, or participant chose not to offer the choices of this and this, participant chose not to take action at this point in time. So, and that again does all those things. You guys are actually taking it a step further in a broader perspective, is letting everyone know why things were done is, so that we know the best care for the patient and following those. And the other one is a change in status or a change in the norm. And that goes back to really the SASH coordinators. When you see someone every day when they get their mail, you don't need to record that you saw them and you said hi when they got their mail. But then when you do see a change in status, a change to the norm, every day when they get their mail, they say hi to you, they seem cheery. But then today when they got their mail, they didn't say hi to you, and they just seemed like they were walking more slowly, and something seemed a little bit off. That's a time to maybe make a case note about it. Like, notice that Betty wasn't the same today when she got her mail. Decided to go back up and check in with her later in the afternoon. And then she seemed fine then, or we realized that she was really tired and called the wellness nurse. So if that helps SASH coordinators to kind of narrow it down, because you do see people so often, that might help a little bit.
What about for people who aren't participants yet, but are working towards becoming participants?
So the question is, what about people who aren't yet participants? So if they're not yet full participants, they're often not yet in DocSite because they have not signed the forms. Yeah. Now, the exception to this, and this often gets confusing, is people who are doing exercise classes or healthy living workshops. We do want to track all that. So we'll put them in there with the minimum level of information, name, demographics, and then just their participation level. So with that, all we would want to record is what they're participating in, but not any real health information about it. Yeah. We really want to be careful not to record any health information until they've signed off on the forms. So that's a great question. And that might be a case where in this darn paper folder, you just keep some paper notes in a manila folder on someone that you're kind of building a relationship with and they're not really joining yet. And then someday when they do join, you can go back and add some of the relationship building you did with them once things are like clear and signed. Yeah.
One question on that, just that same level, when people are not yet fully SASH participants, they're low-level folks, and you're trying to put them in DocSite, they do ask for race. Well, I haven't spoken to that person yet about, I haven't gone through the demographics to decide that. I mean, I could visually do that, but that's not really where you want to go with it.
Yeah. So the question is about that race, and when you're putting in demographics, ask race. There's a no answer option there. I can't remember what it is, but you can put unknown or not answer, because that when we first learned Doxit, I was like, I don't want to mess with race. You cannot answer that. You choose an answer that's like unknown or declined. I can't remember the phrase, but you absolutely, and some people don't want to answer that. So I was happy to see you can definitely just do that. I heard a question from one of the sites.
I have a question. There's a participant that each morning I check in on him and I actually weigh him because we need a consistent weight every day. Mm-hmm. And do I record that, and if so, how?
Yeah, what I would do with that is you don't have to put an encounter note for that. What I would do for that is enter his weight every day in the vitals field. Do you know how to do that?
No, but I could find out.
We'll work on that.
So. Okay.
Oh, okay, yeah. So, Diana, we'll make sure you know how. So you would just enter that weight in the vitals field, and then there's a tracking place. So you would just say, like, you click off, saw him in the home, and then checked off what you did. So there's a couple check boxes, but you don't need to write a case note. The only time you'd write a case note in that case, again, if something's different. So you're tracking his weight every day. Maybe he has COPD, and you want to make sure his weight doesn't go too low, and then all of a sudden something drastic has changed. Then you want to put a case note, and then you would probably do something, if that. So that's where the notes. So they also, so that you guys don't get 10 million notes that aren't that helpful. I'm just going to make another couple quick notes on case notes, and then I'll turn it over to Bob. So this is also from a nursing journal. It's saying good record keeping is an integral part of nursing practice, and in our case, care coordination, because SASH coordinators are care coordinators, and is essential to the provision of safe and effective care. It is not an optional extra to be fitted in if circumstances allow. So again, you just gotta have to make time for this. Good record keeping details the patient's journey through the care process, and I think all of you hit that on the head when you were giving answers. So great job. Good records put the patient at the center of care. They track clinical decision-making and care goals and progress with those goals. So again, so case notes also can happen around their action planning and their goals and what they're doing with that, and that does help the whole team. Last one. No. And then I just want to say the converse of good record keeping. I know this is a really long slide. I'll send these out, but I just kind of want you to hear this, to think about it. The converse of this is that poor record keeping increases workload and undermines patient care and makes individuals vulnerable to legal and professional problems. Specific issues with poor record keeping relate to the quality of information recorded. This can be seen in the use of words such as adequate or reasonable. There's no way to quantify these remarks, and therefore they're open to misinterpretation. Does that kind of make sense? When you're just kind of vague, or what I think of as subjective. You want to really stay away from vague or subjective terms. The use of an abbreviation such as DOA could mean both date of admission or dead on arrival. I liked that example. Potentially a devastating message to pass on. While a good description of facts is essential, health professionals should stay away from making value judgments about a patient's personal circumstances. And I think that one can be really dangerous, that sometimes we just don't realize we're doing. We care about them a lot and we want to help, but I think we definitely need case notes to be objective and not subjective about what's going on. Again, something might be people have the choice to smoke. We can present them with facts and talk to them about health risks and all of that, but if they want to keep smoking, that is their choice. So things like that, so we want to be careful how we record things of that nature. And Bob's going to talk to you about the fact that they have the right to request these records. These are their records. Yeah. Do you have a question?
Just real quick. So for an example is a person who fell, and then there's rumors that she may have fallen because she drinks a lot. And then I actually even saw a half-filled glass, but I wouldn't say that she was drunk when I saw her or anything like that. Does that information, that's not really relevant, I think.
Right. I think that's really good. I think you would have to report, Betty fell in apartment. I think you can say observed glass of wine in apartment when went in there, unsure of circumstances surrounding fall, we'll do further assessment. I would say something to that effect. I think we have some, go ahead, yeah.
Or that you received reports or multiple reports from other residents that they had observed her appearing to be intoxicated. You're not making a judgment on it, but it's not completely hearsay because it's people there so that, you could just put it in there. But yeah, that is an important thing. A lot of people don't realize that is they have the right to request copies of this. So this is not private, internal only notes. These are clinical observations or notes.
Right.
So you want to make sure you're professional in what goes in them at all times.
Yeah, and I think that situation comes up actually fairly often, and it's very hard to assess on alcohol and drug use and medication misuse, and we're working on better assessment. The whole state is actually. And the key there is need for further evaluation. So you are not making any judgment based on what you've heard or based on what you've seen, but you observe some wine, she fell, you don't know why. We'll look into that further, but we're not going to make any judgment. I think that's the key.
So what we're going to talk about today is, for the overview of HIPAA, is what is it, where did it come from, what are the rules, and what does it mean to me? And it means a lot to all of us. So from the learning objectives, we'll go over the background of it, rules, the definitions, the rights, both your rights and the participants' rights for the information, and then we'll do a summary at the end. So first thing is HIPAA. What is it and where did it come from? So in 1996, the Health Insurance Portability and Accountability Act came out, and it gave everyone a federal right to privacy. For those of you who may know, there was no right to privacy on any information prior to 1974. 1974, they came up with the original Privacy Act, which was your Social Security number and that type of information, so you had a right to privacy. This 1996 Act basically brought that to the health information. It also created a standard and gave enforcement rights. For a very long time, there weren't any teeth in the enforcement. And for anybody working at a large hospital or those that reads the news, there have been a lot of multi-million-dollar fines handed out over the last few years. And now they're going from the larger companies down to the mid-sized doctors' offices. Auditing hasn't made its way down to our level yet, but it's coming. It's on its way, and they could at any time do it. The policies apply to all of us. And I say that meaning the wellness nurses, the SASH coordinators, me as an IT person, the custodians that are working for the property, in the building, everyone it applies that may see that information. So some of the covered entities, the health plans, healthcare providers, community health teams, the outreach people, those that have any type of assisted living, and business associates. So business associates comes up more and more now, and it was actually strengthened, the law on this, about 1.5 years ago. So that you may have read recently, there was a hospital in Boston that fired their transcription service because they were contracted to transcribe all these doctor's notes into electronic copy. And they accidentally posted a large number of these narratives on an unsecured part of the website. Major violation, and they were fired on the spot. There'll be all kinds of lawsuits and everything going. So they were a business associate of the hospital because they were contracted to provide a service that gave them access to protected information. So they're just as responsible for that information as the hospital or the doctor or anyone else. There's two main components to HIPAA. One's the privacy rule and one's the security rule. Big thing to know about this is the privacy rule relates to all information, written, verbal, electronic, any fashion, in any context of that information. The security rule is just electronic. So it says electronic, paper, oral. That is called protected health information, PHI. The security rule covers it in its electronic format. So basically, if you have a piece of paper in that record, that is covered by the privacy rule. If you were to scan that and eventually be able to attach a document to their DocSite record, then that would be covered by the security rule as well. Any of your notes that you enter onto the portal, any of the vital signs, any of the surveys, any and all of that is covered by the security rule. Ministry, and there's certain things you have to go through, and you'll see when there's like a breach assessment, you do a risk analysis. There's all these things these steps that go into protecting information. Much the same that an insurance company goes through a risk analysis of how much to charge you for your auto policy based on your credit profile and your age and your sex and all these other things. They come up with a risk profile. They have that as well with the HIPAA information and what the functions are, where it's stored electronically or paper. And so just to hit this again, because it's a key component, the privacy rule applies to all the PHI. The security rule only applies to the electronically transmitted or stored PHI, also called ePHI. The mega rule was created in March 2013 and went into full effect in September 2013, so not quite a year ago. They put some real teeth behind the enforcement. $50,000 to $1.5 million per organization. So they can really hit you. They can put you out of business. I mean, it really honestly can. They expanded some of the privacy protection. They put some new limits on the use and disclosure of the PHI, including actually, to me, lessening the restrictions by allowing it to be sold or marketed. If the information, the individual identifiable information was taken out of it. Gave the individual some new rights. They broadened the scope to include the business associates. So if we as an organization contracted with someone like Covisint to provide the clinical registry, the doc site, to have the information, they're a business associate. So they, by rule now, are just as liable for all the pieces, and we are. So they have to keep the audit trail. We have to know it's there and have access to it. They have to have the physical security on the data center where all the information is. We have a right to ask about it. Then it also altered the breach definition. That's something that we're going to cover in depth when we get to that. What is a breach? What are the common scenarios? And then what do I do to deal with it? Everything has to be documented, but you're allowed to put a risk assessment on it and make a determination of the likelihood of that breach resulting in not unintended access, but those accessed by someone who does not have a right to see it. So again, on the PHI, it can be very specific, it could be very general, but it's health information that relates to a specific individual maintained or transmitted by a covered entity, us, in any form, oral, paper, electronic. So that conversation in the hallway about somebody's blood pressure being elevated this week is just as protected as the most detailed laboratory results that come out of the hospital. And that is key, because almost 99% of any breaches or any unintended access by any of us in this business are going to be unintended. Nobody's deliberately going around spilling the beans. Frequently, you're trying to do what you think is the right thing. But unfortunately, the road to hell is paved with good intentions, and that's just a fact.
I have a question. I'm not sure how the logistics are for my agency yet, but I have a property manager that manages through the housing sites, and I feel like this person has been coming to me, like asking me bits about, because I interact with the participants on a daily basis, and they'll come and they'll ask me things, and I always just say, like, I know, but I usually say, like, I don't know. That's not something I have to disclose to a property manager because they're not on part of the team, correct?
So
okay. Just making sure.
It's a dual thing. So
Yeah.
you're covered by and we'll get to use and disclosure
Yeah.
in different things. Basically, use is internal, disclosures out external. When a participant signs the use and disclosure form, they are legally allowing
Yep.
the use and disclosure of that information to the covered entity or whoever's listed on there. So if somebody signs one for Cathedral Square,
Yeah.
that legally covers the custodian, the administrator, the IT guy, as well as the wellness nurse and the SASH coordinator. Legally, that's covered. What's needed, it's our responsibility to only use it for what's required in our duties. So, that can be a tough thing.
Yeah, because I feel like a lot of people always just want to know information, but it's not information that they need to know. So it's
Well,
just finding that line.
Exactly, and finding that line is going to become really, really important. And for the organizations where you want to build a strong relationship between the SASH coordinator and the property manager, and that's going to be really important. So what's important, Bob's going to talk about minimum use, and it's that need to know. So when it works really well, what happens is the SASH coordinator specifically and the property managers build this really tight relationship, and it's bi-directional. So sometimes it's a property manager who comes to the SASH coordinator and says, look, let's look at this individual because I was in doing an inspection and there's a hoarding problem. I'm going to have to give a lease violation letter, but can you work with them to see what you can put in place in the home to help them work with this issue? And that's a great relationship. So then you can come in and kind of say, like, let's talk about what's going on in your life and work on that relationship and look at it from that angle. And they're the ones who usually have to be like, give them the lease violation letter and have to do that different relationship. So that's great. So you're working on a specific issue. You don't also need to go, oh, well, they're also an alcoholic and they've got high blood pressure and da, da, da. Minimum use, but say, yes, let's work together. In that same vein, though, if that property manager is coming to you wanting to know about someone, you might want to say, well, tell me a little bit more about why you need to know, because they could be in a situation where they're about to give a lease violation letter, and they might want to know from you, are you working on something with them? Can we work together? So it might be good to ask why. You also could just have a busybody. And in that case, you're doing the right thing by just saying, like, yeah, I'm not really sure. So it does, as a SASH coordinator, it requires a lot of judgment calls around that. But that's going to be a key relationship in organizations where you have a SASH coordinator and a property manager to really work together. And when you do work together, it's great. It really works well. And frankly, it's nice to be the SASH coordinator in that, and that end of things. Yeah.
It's also very acceptable for them to understand as part of your relationship, you're on the care side, they're on the property side. Mm-hmm. So the expectation could very well be that it's an 80-20. They're giving you information and observations 80% of the time, and 20% of the time you're giving them some feedback for what they need.
Mm.
You know what I mean? So there's nothing wrong with the vast majority. It's not an equal conversation over lunch. They're feeding you information and observations to assist you and the wellness nurse in, the care of that participant. What do they need for their job? They don't need to know as much as you do. And it's there. So legally you're covered, ethically, it's a pretty gray line sometimes, and you just have to, and that's where the strength of the relationship comes in for them to understand.
I have a situation.
Oh, sorry. Yeah. Go ahead.
I have a situation that would be nice to have an easy way to handle. I oftentimes hear the residents standing in the hall, and there could be 5, 8 of them, and they are talking about, someone's medical information because they heard about John Doe having a heart condition. They're worried about him falling. And I know I can't discuss that with them. Sometimes I walk out into the hall and someone will say something to me and I immediately say, I'm sorry, I can't discuss that with you. And that's the way I handle it. Is there a better way, or is that the only way?
It's tough. I see it all the time, but the thing to remember is, where did the initial information come from? It should have come from that participant, not from an employee, because it's their information. They can say, I had one the other day where I was sitting there, and at least a dozen times in 45 minutes, one person was telling everybody that stopped for 2 seconds walking by about so-and-so having gone to the ER and, was admitted to the hospital, and, the prognosis isn't good. It was out of genuine concern, maybe a little bit busybody, but predominantly. And one thing actually Stephanie came up with is, what you could do is, so everybody's bombarding you with questions out of genuine care. They live together, they're their own community. And so the suggestion was, potentially you could go to that person who has the issue, you're going to be working with them, and say, a lot of the people in the community are very concerned about you. Is there anything that it's okay to share with them? They're just genuinely concerned about how you're doing. Is there something that I can pass on to them? And then they know about it. They're letting you know what information is okay to give out, and then you can pass that on. But if they say, I don't want anybody to know what's going on, then it's sealed lips. That's the way it is because it's their information. It's their right, not yours.
And that's exactly right. And Diana, what you have happening is happening everywhere. And I'm sure we've all experienced it. And I think you're handling it really well. And I think if for any reason someone were to say, well, you should tell us what's going on, or they push back on that at all, I think the best thing to do is to say, I think if it was you in the hospital, I would want to respect your privacy as much as this person would want their privacy respected as well. And you could have someone who goes, well, I wouldn't care. I'd want you to tell them everything. Say, well, great. I'm glad to know that for when you got,
When you're sick, then I'll tell everybody.
Then I'll tell
all
everybody.
about it.
Right. So I think you're absolutely
I do
doing the right
mention
thing.
that.
But sometimes, though, all the little gossip ones, like if something happens on a weekend, somebody goes to the ER or falls. When you come in, they're the first ones to tell you. So then you're like, oh,
Right.
okay, I didn't know that. And then you can
That's
go
great.
check it out. So it kind of works both ways.
Let's
in some
face it. What
instances.
else do they have to talk about sometimes?
Yeah, exactly.
When you run out of the
Each other's-
grandkids stories, I mean, it's.
No, but Marcia, you're right, because that is good. That's part of the benefit of it's true. Unfortunately, we'd love for the ER to let us know who's in SASH and and let us know when they go ER. But that's great. So yeah, you can be like, oh wow, thanks. I'm glad I heard that. And then we go research. We
You're
receive
receiving
Right.
the information.
Exactly.
the receiving.
It's
We're
not a reciprocal
Yeah.
agreement.
So you guys are doing great. It's not fun. You're doing it right. Yeah, absolutely.
At my site, they know better to ask me anything because they know I won't tell them nothing. Don't ask her;
Yeah,
she
with-
can't tell you.
They know with
Yeah.
it's interesting. They won't ask nurses. They know that nurses have this licensed thing. They will not do it, but they'll push on the SASH coordinator. So you guys have the much tougher role,
you
I
ha-
think.
It's the requirements are exactly
Yeah.
the same.
Yeah.
They are no different. SASH coordinator, custodian, or wellness nurse. Now, how much information would change by your job position, but your duties for protecting their privacy are exactly the same.
And for instance, as they said one time, I heard that I'm changing the names, John and Jane fell and both went to the hospital yesterday. And it wasn't accurate information, but I couldn't say either. And I said I really couldn't discuss that. And I knew that half of it was right, half of it was wrong. And that's what I'm saying. And I think after a while they'll realize that that's always
Yeah, we're
going to
not
be the
the
answer.
clearinghouse. I mean, obviously, if the stretcher's in the community room and that's where they fell and everybody's standing around, then they know they went to the hospital. But, so you can use a little common sense there. The next part I want to talk about is the identifiable health information. What makes it identifiable? And a lot of people think they can get cute using initials in an email, and we've got the nurse and I have this code stuff worked out, so we text back and forth and all that. You're really, really on a slippery slope. Just about all of our properties have an open doorway or vestibule to get into, and most of the time the people's names and apartment numbers are listed there so they can, buzz in. So if I know that JP initials has COPD and lives at Macaulay Square, I can easily find out who that is. So texting is not secure unless you'll know if you're paying for the secure text messaging services. For those that are Cathedral Square employees or working at our sites, we do have the ability to send and receive secure email messages. The VNA has it, a few of the others. But if you don't know that you're sending encrypted secure messages, you can't just get by with initials and some of the cute things that people have tried to do to get through, because your definition of what's identifiable and another person's could be completely different. Let's see. So use versus disclosure. So I'm going to read, I don't generally like to read slides, but I want to make sure everybody gets this one exactly. Use is the sharing, utilization, examination, or analysis of identifiable health information within a community that maintains it. Use is an internal function. The SASH coordinator has the ability to use the survey information in DocSite to work with the wellness nurse and the participant to come up with a healthy living plan. You have the ability to track their weight because you've weighed them every day for a month with the nurse. When you disclose, when you take that information, that month's worth of weight, and you're working with the primary care physician, then that becomes disclosure. You're disclosing that information to an outside entity. In this case, it's perfectly legal and legit. You know, they've signed the use and disclosure form so that you can share that information with the Area on Aging or the VNA or their doctor or whatever the organization is. But use is within your community or your organization, and disclosure is outside. So it can be the same information passed on in the same fashion, but when it's outside your organization, then it becomes disclosure. And that's why there's so much going on with Vital, the Health Information Exchange, the Community View and DocSite, all of those, is because of the complexities of the disclosure. Use is easy. That's inside your organization. You put it up there and you give whoever has access to that panel can see the information. The disclosure that's outside, and that's the whole point of this Health Information Exchange, is the disclosure and the sharing of the information to improve the care. But Vermont is one of the most difficult states in the country for our own state laws for the use and disclosure, in that we're an opt-in, not an opt-out state. So unless I sign something, I'm out. I am not in the exchange. And a lot of times what I try to do is I try to put myself in it, you know, so if I have something medical going on or I'm dealing, you know, everybody's a participant at some level with this, and you have your own health information. You know, how would I feel? I had a personal experience where a family member was at a facility that was a covered entity, and she had a right to privacy on a certain thing, and there were two staff members discussing what was going on, and they were in a room. They weren't out in the hallway, but they didn't have the door closed. You know, sound carries very well, and from that conversation, other people learned about what was going on with her, and it made for a very, very difficult time for her for the next few weeks. You know, so I mean, it's real. It's not just on paper. It's not just another government entity trying to support itself and make all these rules. You know, real harm can come from this stuff. It can be really mean. I've gotten letters, I don't know how many times over the years, from the Veterans Administration apologizing yet again for another laptop being stolen and my social security number being out there yet again. You know, if I get hit with identity theft and it just you know, I mean, it's real. And we need to have good stewardship and guardianship of this information. They're trusting us with it, and that's a real responsibility. So this is a question here, see if I can get an answer. Which definition describes the use of PHI?
Sharing identifiable information within.
Right, within a community. Yeah, sharing it is within, all the others are to the outside. Participants' rights. They have rights, whether they know about them all or not. They have the rights, and it's our duty to honor their rights, whether they request them or not. These are their rights, and that they have a right to see and to get a copy of their medical records. So that's what we were talking about earlier with the notes. Well, so-and-so was just a complete bitch to me today, and I think she's just taking her meds at the wrong time, and I'm not happy about it. Well, that is now part of her permanent electronic health record. They have the right to see their records within 24 hours, excluding weekends and holidays. They also have a right to buy copies of the records within 2 business days. So if somebody's got a couple of encyclopedias worth of health information out there, and it's going to cost you $150 in color copies to print it out, they have the right to request it. You have the right to bill them a reasonable fee for that. Past participants, so once they're out of the program, they have the right to review and obtain it, and federal law says you have up to 60 days to fill out the request. These don't happen very often, and you don't necessarily have to memorize this. You know, we're available to help. Everybody, you know, refers to it, but you know, they're out there. They do need to submit the request in writing, and you do want to keep a copy of that. So that's another legal document. So you want to have that, and you're allowed to charge a fee. It's the way it is. So they have the right to it. you know, you don't have to come in at midnight on a Saturday to give them the copies, but they do have the rights to it. There's a couple of exceptions, and again, with these, it's going to be the doctor and the nurse and everybody really helping out with these. But you can deny the request if it doesn't exist. You know, that's easy. That's an administrative type function. If there's legal action going on, but again, the lawyers are involved, so you're not going to be the one deciding whether it gets out or not. The lawyer's going to. It's a research study. Again, you know, it's kind of vague and out there. If you deny it, you have to report it in writing, and they have a right to see any list, a list of any disclosures. So as the information's being given out, you have to keep track of this as it's shared with the other. That's where the audit logs come from like the community view. You know, so the primary care provider can see the results from their office. The audit log is there. Covisint keeps that, so it's available to be produced in there. Another right that they have is to request restrictions. So they can give a use and disclosure statement, but they can also say, I do not want my children to see this information. It's theirs. They're an adult. They have the right to it. Anybody that has a child that turned 18, you'll know. I mean, if they turn 18, it doesn't matter. If they haven't signed the form, you're not allowed to get any information just magically in that one day. So the example is the request that certain family members not have access to the health information. Another one, I can't remember if I put it here. No. Another one that's not in here, but you have the right to refuse a disclosure if it would be detrimental to their health. Generally, that's psychiatric type information. So, and again, a psychiatrist and an MD is involved in that, and they'll really be the ones making the decision. But there is a right to deny that information, deny a copy to them if it's deemed detrimental to their health. But that's really most of the time going to be an MD making that decision, not a coordinator, or maybe not even a nurse. It's a little great. So when you get into those, certainly seek out help from those that are allowed, because you can ask without giving up the privileged health information. You can get support and help as to, you know, how to handle a situation. And you get a couple of days to do it. So, you know, you want to be careful with that because you can't unring the bell once the information's been disclosed. So just summarizing, as you can see, the privacy standard of HIPAA gives participants several rights, and it's our responsibility to uphold these rights. This is a copy. It's also was an attachment in the email of the privacy and confidentiality acknowledgement statement that every Cathedral Square employee signs. Every single employee is part of the intake. You sign this. In a previous job, I was an IT consultant. I can't tell you how many of these I've signed. I had one where I had to sign it. The entire company, every single person in our company had to sign it before they would even disclose the address of the place where we needed to go fix the computer. So it was a battered women's shelter. You know, you do for police departments, you do everywhere. You know, it's all kinds of privileged information. So no one should have an issue with signing this. It's just basically common sense. I will respect the privacy and confidentiality of any information that I happen to see in the course of my duties, and I'm not going to disclose it. And it's a condition of employment.
And just so you all know, we've shared, this is again on the operating manual, and we've shared this with the privacy officers at all of your organizations just as a best practice, so that if you're not already signing something in your organization, then this would be something good to implement. It really covers you as an organization. So as SASH coordinators and wellness nurses, this isn't your decision to implement, but if your supervisors don't already know or they're interested, this is there as a template, and then you could take it and modify it for your organization. That's why we include it. But it's a good idea to have. They now all know. Before, a year ago when we did this, they weren't as aware, but they now know.
But, you know, it covers about passwords in here. Can anybody give me an example of when it's okay to give out your doc site password to anyone? What's an acceptable? What's that?
Never.
Nice. Good answer. Never. Even as an IT guy, if I'm working on somebody's got an issue, it's like, okay, can you type your password in for me, please? You know, if it has to be reset, it's reset. You change, you know, you're forced to change it immediately at the first log on. So what that does is you have to change the password to something only you know, before you get through the doorway and to get access to the information. I know it's a pain sometimes. Oh, can I get you to sign on again? Oh, can I get you? But that's it, because that's yours. If your password, if that information becomes compromised, then anyone has access to all of that information, because you can get the doc site from anywhere. It's not restricted to your building or where you can get to that portal. So the only line of defense between a hacker or somebody and that protected health information is your user ID and password. You don't write it down and you don't give it out, period. So they also altered the breach definition. I'm going to pick it up a little bit. As of September 2013, so it's the unauthorized acquisition, access, use, or disclosure of unsecured PHI. It's presumed to become a breach. So you're guilty until proven innocent. Any information that's not properly contained becomes a breach. The severity of the breach and your actions then come after that. You have to notify and do things unless you can prove that there's a low probability that the PHI has been compromised. So my favorite example that I read of all of this is, I was on a cruise ship, I had PHI on a flash drive, and I accidentally dropped it overboard into the ocean. Okay, there's a low probability that that information will become compromised and falls into somebody else's hand. So you document it, but you don't have to notify anybody, because it's very low probability that some fish is going to spit it up. Fish will eat it, guy will catch it, he'll know what to do with it. You know what I mean? It gets a little bit ridiculous, but it was a breach. That protected health information is no longer secured. So the exceptions: good faith and unintentional acquisition, access or use by a person working under the authority of a covered entity. So you leave some paper files out on your desk that are not locked in Stephanie's cabinet that we talked about, not just in a lockable cabinet, but in actually a locked cabinet. So you leave them out, they come in, do the cleaning, and they see it. That's unintentional, but it is a breach, except that the person doing it happens to be an employee of the organization. So therefore, it's not an issue. If it were a contracted outside person that has not signed the information, then it is a breach. So we had an example. I went to a vital seminar in Rutland in one doctor's office, smaller doctor's office, but they were just into it. They were just pumped up for HIPAA. They were doing everything. They were so perfect. They had them come in for an audit just to prove how good they are at everything, and they flunked them 10 seconds in, and they just couldn't believe it. They were properly putting all paper documents into the bin to be shredded, but they were not shredding them before they left at night. The cleaning person that was contracted from an outside agency was coming in and emptying the recycle bins into the shredding area. Major violation. Had they just taken it and gone into one of the, secure shed's got the secured bins, or had they actually shredded it, they were fine. And that's about all they found. But it's like, no matter how good you are, there's something. So you have to think it all the way through. It's one of the advantages for us with almost all the information being electronic. A lot of that back end, the secure computer center, the access, the firewalls, all that stuff is done under the contract of Covista. So we don't have to worry about that. It's another reason why we're trying to keep the paper records to an absolute minimum. And so that you don't have to access that paper as a routine part of your job. So it can be in a locked filing cabinet, maybe even at the central office, because you need it on record. It's legal documents. You got to have it. But if you don't need to use it as part of your routine day-to-day job, then it's easier to keep it secured. Disclosures between persons in the same covered entity, business associate. So you're talking and you accidentally say a little bit too much to the property manager. Again, it's covered legally because it's under there, but it still is a breach, but it falls under the exception piece. Oh, here it is. I did have it in here about the thumb drive overboard on a moving cruise ship. I guess if it was stopped, it might have gone a little differently for them. So part of the forms we have available, I think they were in the
brief.
packet that went out, is to help you. So you're not just sitting there going, well, what is it? You know, there's a nice checklist. And there's actually, when we did the privacy training for all the housing officers, we talked about there's 3 different really forms to go through. There's an investigation report. So it helps you ask the questions. So it's more of an interview. So you write down the answers, and at the end, it helps you summarize or ferret out the information about whether it was a breach. Every organization has a privacy officer. Do you know who your privacy officer is? For all of you at Cathedral Square, it's Kim Fitzgerald. It's the Chief Operating Officer and CFO. I am the Security Officer for Cathedral Square. Pretty much, its executive leadership has to be the privacy officer, so that there's a culture in the organization of privacy and wanting to adhere to this. So it can't be delegated down too far. But you really need to know who it is, and it's their responsibility. They're the go-to-jail people, they and the security officer, if things are egregious and wrong.
I want to mention something on this form for a minute. So all of you, we sent you this form on the packet. So I guess on the left-hand side of the screen. And this is a really nice form to have. And people often ask me, what's the exact protocol if we feel we have a HIPAA violation? And the answer is there isn't one protocol. Basically, if you feel like you've had a violation, you have a couple of choices. You may want to take this form, which is really easy to walk through, and just fill it out yourself first. It'll probably put you at ease a little bit. I can tell you that the majority of the things that are going to be HIPAA violations that you all will encounter will most likely fall under those 3 exceptions that Bob talked about. They're unintentional. They're generally pretty small. They're going to be things like the file left out on the desk, or the file cabinet wasn't locked. Do your best to have that not happen. But when it does, we do need to document it. So walk through this form and fill it out. So you could walk through this form first yourself and then bring it to your supervisor or your privacy officer and say, here's what happened. I went through the form. I think it's going to be minimal risk. What do you think? Or you might be like, oh my God, this happened. I don't know what to do. And just go straight to your supervisor, and they're going to say, great, let's walk through this form together, fill it out, and we'll see what to do next. And you'll assess it. And basically, by the end of the form, you'll assess, is it low, medium, or high risk? They need to notify Cathedral Square, and it's pretty much going to be documented. We've had a couple things happen so far in the last couple of years. They're all very minor. They were documented in a couple instances. They have had to let like the home health agencies know, and I think in one a participant know, but very minor, very much like the cabinet was unlocked and a maintenance person might have seen the file, but nothing was really compromised. And it's all about just documenting. As long as it's documented, and then you make a decision about the risk level and who needs to know, you're good. So this form is really nice to have. Keep that in your back pocket, not let your figurative back pocket, and just talk to your supervisor when something does happen, or even before it happens, so that you know. Just say, do you want me to take a stab at this, or do you want to do it together? What's the best thing to do? So they've seen it and you've seen it, and it's there, and that will really put you at ease. So it's a great tool to have, and that's really your first step when something happens.
But it is the privacy officer's decision, no one below. So
Yeah.
you fill it out, you talk to your supervisor, you work through it because you want to provide the information. The privacy officer will forward it on to Cathedral Square as the statewide lead, but it's the privacy officer's decision, no one below them, about the final decision. I mean, common sense.
risk
can break
level
out.
and what-
The risk
yeah.
level and all that, because it's their decision, so it has to go to that level.
And that's actually nice for all of you. You guys are like, this is what happened, and then they decide. And that's why we don't want it at the staff level, and it shouldn't be. So it's good.
So this is a great example because this happens far more often than people realize. So you accidentally fax a participant's visit medication list to the wrong doctor. The nurse calls you and tells you that a person's not a patient and they shredded the med list. Is this a breach?
Yeah.
Yeah.
Do you need to fill out a notice of breach report?
Yes.
Is it likely that their information was compromising and get it out there? No, it's a pretty low risk. And depending on which doctor, in the same organization and all that. But that's why you always have that disclaimer at the bottom of the fax form. If you don't, you need to. legal definition. You know, if you are not the intended recipient, you know, blah, 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 blah. We have that on all outbound messages from Cathedral Square. So you won't see it employee to employee, but if you send it to someone outside the organization, there's a footer at the bottom that's a confidentiality statement that says if you're not the intended recipient, it's your obligation to not read and to delete this message.
That's on fax and email you're talking
Yes. So fax, it's on the bottom of the cover sheet as it goes out. In email, it'll be on there as well if it's outside the organization.
The
Questions?
cover sheet gets generated by our fax machine, or this is a piece
No,
of
it's
paper?
something that'd be a written one. Not too many people fax anymore, but it's supposed to be there. Because if it doesn't and you send it to the wrong place, then it's open. You're not covered with that statement that's on. Even though, I mean, if somebody wants, you know, does it really do anything? Well, it covers your butt.
I sort of made my own form. Is that fine? Because I wasn't provided with one, so I just sort
I
of...
would check.
Okay.
Because generally you want it signed off by a lawyer because you're trying to cover a legal exposure.
Yeah.
So the lawyers are the ones that, you know, can say that for the organization. So you're probably okay. It's certainly better than nothing, but it would be worth following up on, you know, as far as policy. Because again, as we talked about when we did the training for the privacy officers, we were starting to go into it as, you know, this is all new. It's HIPAA, it's medical information, you know, we're going on. And then we had a meeting and Molly kind of had an epiphany. And it's like, it's really not that different. Housing people have always had income information, social security numbers, all this. So it's different, but it's the same. You know, this expectation of confidentiality and the fact that we have privileged information of one form or another that we need to protect. So this other case study we kind of talked about already. Betty was taken out by ambulance. You've been in touch with the family and a hospital case manager. Another resident comes up and asks you how Betty's doing. What do you say? You really can't say
Sorry,
anything
can't
unless
discuss
Betty's
that.
said. Yeah, unless Betty's, you know, but, you know, this is where you can put the personal touch on it and you really build a relationship with the participants is, you know, making that extra effort to talk to Betty and say, Betty, they're really concerned about you. Is there anything you'd like me to tell them, you know, about how you're doing? You know, that's going the extra. And then, you know, you're not violating anything, but you're also, you know, trying to help people out. So just to summarize, HIPAA is a very lengthy and complex set of rules and requirements. It's technological as well as personal. You know, all the password changing, you know, there's just incredible amount of stuff. Our security policy runs to about 90 pages. That's part of this. You can't know it all. There's people, entire businesses that have sprung up just ensuring HIPAA compliance for hospitals, even organizations. My previous job, we ran a data center. So we spent an extremely large amount of money to a well-known consultant to define the policy and design it for the organization. So it's big business, but we can start we can start by focusing on the highest risk. The written forms are huge. Like I said, you know, the incident of the lockable filing cabinet versus the locked filing cabinet. You know, leaving stuff laying around. Your computer screen. Walking away from your screen, even if it's not up, with DocSite, you know, on there, and you're walking away and you're not near it, anybody can sit down and read it. It's so simple to give the 3-finger salute, right? For those you don't know, Control-Alt-Delete on your computer, hit enter, and it's locked. Verbal conversations. I mean, they really almost always are unintended. You're so focused on whatever's going on, and you're trying to get it good without being aware of where you are. This can go to, and this is where the organization can help out. Because if you're not given any private area to have discussions, how could you be expected to have one? So this is where the organization needs to step up in whether it's a conference room, whether it's an office with a closed door, in some way, or you just really have to watch, you know, the sayings. But verbal conversations are just ripe to be overheard by the wrong person. And it's the same as if you printed off a copy out of, you know, of a record out of DocSite and handed it to someone. It's just as much of a violation. Email threads, again, some people, you know, trying to get cute with disguising it and all that. It's like, just don't, because it's going to go back and forth, and you'll forget that, you know, 17, threads down, you had all this detailed stuff, and now you're talking about meeting for the concert tonight or a drink after work. It's just bad practice. If it's privileged health information and it's in an email, make sure it's secured or it's within your organization. And there you need to talk to your IT people. Anybody within Cathedral Square, I know it's encrypted if I'm sending it just within the organization because that's how it's stored. We have it internal, it's data at rest.
With
mileage
verbal
may vary.
conversations, I want to add, with verbal conversations, people often think that people can hear as well as they can. I have exceptional hearing, and I often hear conversations that other people might not be in it. So there are people that have great hearing and can hear in another room. And so just because someone doesn't hear very well doesn't mean other people are not hearing much better.
Right. And then there's people like me, and especially my daughters, that are much louder than we think we are. So it carries, it's just, it's again, you need to recognize, your antenna go up with these written forms and all that. And that's what we're trying to accomplish is you're aware. We're trying to make you aware of this and the potential. And then, again, the doc site access, the password, that's the key to the kingdom, and you've got to protect it. So we're just trying to get a baseline, make people aware of it, to know it's real. It's not just another bogus thing you have to do, and to get you to treat their health information, with as much privacy and respect as, as you need to. Okay, so just for some discussion points or things to think about with this is take a look, kind of a step back at your daily practice, your organization, your facility, your SOP, how you do things, right? Standard operating procedure of how I go about my day. And just kind of analyze it and see where are the risks. I frequently, I'm in and out of the office and just, okay, I need to start every time I get up out of my chair. Before I stand up, I lock my computer screen. Then I stand up and out I go. Because if I'm not doing it right then I may leave it unlocked. People walking by. I need to switch my desk around in my office because when I'm sitting here typing, I have this new, neat, large dual screen monitor set up, which is fantastic. But anybody walking by out in the hallway can read my screens. So either I need a privacy filter, which will go on so you have to be, dead straight onto it, or I need to look at rearranging the office because it's easily viewable by someone. So that's kind of just, running through your day and your layout and looking at it. It has to be written down. If it's not written down, it doesn't exist. Release and disclosure forms, all those things you need to do. And one thing I'll tell you with HIPAA that seems counterintuitive, but it's just the way it is. It's actually worse to have a policy and not follow it than it is to not have a policy at all on something. So I will tell you that anything that is written down, anything that's a policy for your organization, you need to follow it, and you need to document that you followed it.
I'll just add that in the beginning, I think people were skeptical of SASH because they said, why is housing getting involved in healthcare? And that was 3 years ago. And now people have really seen the value in SASH, both, healthcare organizations, all of our partners. So I think the tide has really changed. But in that, we've always felt, I think we continue to feel like we're under extra scrutiny because housing organizations are doing something a little bit different and being involved in healthcare. And people are saying, well, do they really know what they're doing when they're handling healthcare information? And so for that reason, we have these written policies, we have the forms, and we can show we do know what we're doing. We're taking it very seriously and with extra caution. And kind of a little bit of what Bob is alluding to is we found out that some healthcare organizations or other areas don't have as many policies written down or procedures. They're doing it, but they also can't get caught not following it. But people have been really impressed with what we've put in place, but we do need to follow it. And the other thing that I always leave folks with too is to know that you will make a mistake, and it's okay because the big organizations make mistakes. I've had Fletcher Allen send me the wrong person's information, medication lists, and they all do it. It happens, and then it's what you do when it happens. It's just like making a mistake. So we're going to be as cautious as we can. I think that locking your computer anytime you get up, making sure that file cabinet is always locked and that you have that, just keep that key on you. putting those procedures in place so you get used to it are really good things to do, and it'll minimize your risk. And then when it happens, if it happens, it's okay. Just take the right steps. And I think that's really the key.
Yeah, you can't eliminate the risk. You can just minimize it.
Yep.
But thinking about it, just being smart about it, you can really minimize the risk, and that's what we're out to do. Minimize it, and then when something happens, give you the tools, the ability to analyze it and make a determination and go from there.